the biggest gap in care of women is between about 40 and 55. I would argue, and I really push this in my practice, it is the most important time for women to get high quality medical care. And I can tell you, as a woman who's been experiencing them now since I had chemotherapy for my own breast cancer, my husband, who lives with me, obviously, and I have these drenching sweats in the middle of the night. I mean, he says all the time, if men had to go through what you've been going through for 10 years with this, like, we would have a cure by now. And the good news is we're moving forward with science, and we're getting much better at understanding what's causing these. Women and men and their partners are not talking about it. And then what happens is they start to have sex very infrequently, then they stop having sex, then they're not talking about it. It becomes the elephant in the room.
Raw, uncut, and unapologetic. Welcome to Men Talking Mindfulness.
Ever whispered to a buddy, "What's got into her today?" Well, it may be her hormones running the show. Dr. Lisa Larkin, Doctor of Internal Medicine, Women's Health, and Menopause, joins us to bring the truth, the science, and hopefully a few laughs so you can finally become more relationship savvy and maybe stop sleeping on the couch. Welcome back to Men Talking Mindfulness. Dr. Lisa Larkin, thank you so much for joining us today.
Thank you for having me.
We're excited. And Will, always a good thing to see you. How are you, my friend?
Great. It's good to be here. Lisa, thank you. MenTalkingMindfulness.com, everybody, for what's going on out there with us in the world. So just one breath, grounded practice. Here we go. Let's exhale your breath all the way out. Just let it go, get empty, feel that emptiness, right? Take one big, giant inhale, fill all the way up. Bigger, a little bigger, more breath. Hold here at the top for 3, 2, 1. Exhale, let it go nice and slow. Good. Awesome. Hey, and thank everyone for being here, for tuning in. Leave a review, like, share, subscribe, all that great stuff. Maybe even drop a text message to one of your friends when you're enjoying this episode. So, all right, Dr. Lisa, great to have you here today. Let's just give us a little background, why you've gotten into this wonderful work that you're doing.
So first of all, I've been a practicing women's health internist for almost 35 years now. And from very early in my career, it was very clear that midlife women, particularly around the menopause, weren't getting adequate care. There were whole gaps of symptoms and things that they were experiencing that weren't being addressed. In fact, they were being ignored. And my interest really stemmed from that experience, which is that we had to find a better treatment approach or management approach to midlife women. And it led me to develop my expertise and involvement in the menopause space from very early in my career. So I've been doing menopause, perimenopause, female sexual dysfunction, midlife women's health, and healthy aging for 35 years now.
So we've clearly got you on what is predominantly a men's show.
Yes.
And, why do you think, or why would it be important for us as men to understand women's hormones and women's hormonal health? Like, what do we gain through that individually, collectively, by knowing more of this?
So absolutely. I can tell you that I think it's critical. And I think in our approach to women's health, we haven't done enough to educate men. When women become pregnant, there's a lot of resources available, and men, particularly first-time fathers, are really engaged in that. They kind of learn about pregnancy and what's happening. Menopause has been completely neglected, and menopause is a very, very important time in a woman's life, not just because she's experiencing symptoms, but because there are huge physiological changes that are happening that affects her body, but affects her mood, affects her sexual function, affects her sleep, and affects other things, cardiovascular risk, bone health, all the other things that you can't see. But this is something that we've ignored. Women don't have adequate information about it. So there's been a gap in really just us focusing on giving women the tools they need to understand menopause. But women are in relationships, often with men, not always with men, but the changes that are happening to them affects the entire family, but certainly it affects their partner. And there's so much that is happening that is related to biology and changes in hormones. And I think men don't really understand that because men age very differently than women. I talk about this all the time. Women age in fits and starts. Men age very gradually over the course of their whole lifespan. And it really reflects very significant differences in what's happening hormonally across a woman's life versus a man's life. And if what we know is that the peak times, for example, of mood disturbance for women is puberty, postpartum, and the menopause transition. And the things that they have in common is that they are points when there is huge and abrupt hormonal changes. And men don't have that.
Mm-hmm.
And particularly at menopause, or this menopause transition, which in the United States for the average woman is 51, but there's a bell-shaped curve, so it can happen younger than that and older than that. But the perimenopause, those years leading up to the menopause transition, so this is typically early to mid 40s leading up to 50, is the beginning of these hormonal changes. And this is when women are aging, their ovaries are aging, they're noticing all of these new symptoms, and there are many symptoms that often impact men and their relationships, and we know from studies it impacts their work. And men have no concept of what women are going through because they just don't experience the hormonal changes the same way, and
Yeah.
men and women are fundamentally biologically different. And so I think in terms of just relationships during the menopause transition, perimenopause, could really be improved if, it's all about communication and understanding each other, right? So if men had a better understanding, I believe, and I think there's data to support this, of what was happening to their partner and that it wasn't just all in her head, she wasn't crazy, but the fact that her libido was lower has a basis in biology. It's not that she's not attracted to her partner anymore. And particularly when it comes to what's happening in the bedroom, around this time, there really needs to be good communication because things do change. What I often say is, and we know this from studies, that women have often, not 100% of the time, nothing in menopause in medicine is 100%, but often have declining libidos in the 40s. And when they become menopausal and lose their estrogen, it often gets worse, and they often have other sexual issues. Men have very gradually declining hormone levels, and they typically will have very preserved libido still in their 40s and 50s. And this is a time where there's a big disconnect. And so there's often really relationship problems that sometimes have to do with this sexual disconnect. Sometimes it has to do with having difficult teenagers at home or being in a marriage that's just had problems for a long time and you're getting tired of it, right? Like there's all different reasons for what's happening, but there's definitely many times a real biologic component that men need to know about.
Wow. There's so much to unpack there. No, John, go ahead.
Yeah. So, I'm married. What and my wife is 40. I won't say, but she's 40 something. I'm 48.
Perimenopausal, right?
I'll just say I'm 48 and she's significantly younger than I am. But what kind of things should I be looking out for? What kind of things should she be looking out for so that we both know what is happening?
Well, first of all, and again, this is not a program that's focused on women, but the biggest gap in care of women is between about 40 and 55. And I would argue, and I really push this in my practice, it is the most important time for women to get high quality medical care and to really address and understand what's happening in the perimenopause and the menopause transition. Because what is happening between 40 and really 60 in terms of how a woman is transitioning through that, what her lifestyle habits are, how her health is being managed, sets that woman up for a good or, health span. Like not taking care of yourself between 40 and 60 has huge impact going forward. And I say this all the time. I've been practicing a long time, as I told you, and, I have many patients who are in their late 80s now and in their early 90s. I have some patients with me who remember when I was pregnant with my daughter and she's now 32. So that tells you how long they've been with me, right? So I've aged along with my own patients. And what I can tell you is when I take care of my 85-year-old patients and my 90-year-old patients, and I adjust their blood pressure medicines, or we think about ways to reduce their risk of stroke or falls, the impact that I have is relatively small on what they're going to end up dying from or what they're going to how long they're going to live. But with an early 40 to 60-year-old woman, if I can really take good care of her and empower her with understanding this menopause transition and things that she needs to be doing to take care of herself, I can set her up for a much better and longer health span. So that's really
Yeah.
talking to the women.
Mm-hmm.
Now,
Yeah.
when I talk
Keep
to the
going.
men,
Mm-hmm.
or you about, what's going on is understanding, first of all, that this is a time when hormone changes are happening and women notice this themselves often in many ways, which is change in their menstrual cycle. They can have change in bleeding patterns. Cycles can become shorter, they can become longer, they can miss them, right? So bleeding and menstrual cycles change. But the other thing that women often notice very quickly is they just don't feel like themselves anymore. They feel more fatigued. They do notice that their libido's down. They used to be great sleepers. Now they're not sleeping as well anymore. Often they feel a little anxious or they feel a little depressed or their migraines are worse. Like there's all kinds of things that women come in complaining of, and they're subtle, and all of those things impact relationships, right? And if men have the perception or don't understand that there's really biology playing in here, that these are all things that, when all those things are happening, that woman should be talking to her doctor about those things, because this is what I do day in and day out to help her address her symptoms and set her up for a long health span. But from a man's perspective, if you understood, and let's just take libido as one, common thing that impacts relationships. If you men understood that that was really biology, change both in testosterone and estrogen levels, and that all of these hormonal swings that women were having during this period of time was real biology and didn't have to do with the fact that something was wrong in your relationship, or that, she was deliberately trying to ignore you or whatever. And having communication about that, because trying to maintain intimacy and a healthy sex life as women are transitioning through is really important. And it just takes really good communication and understanding. And I think, again, knowledge, and you tell me if I'm wrong, if you really knew that this was biology going on, doesn't that make it a little it's,
Oh, yeah,
how to
for
accept this
sure.
a little easier.
Yeah. Yeah.
Oh, absolutely. And you talked about for the women that if you were to address the symptoms earlier on, so if you're helping in their 80s, there's not a whole lot that you can do. What are you doing for the women in their 40s so that
Right,
they can be
right,
stronger,
Yeah.
live that longer, healthier
right.
Yeah.
life?
So there's many things. Well, first of all, so symptoms, so the irregular bleeding, the very variable hormones levels that are worsening to their migraines and making their periods heavy and them just feel completely off, is often very well treated using continuous birth control pills. Continuous low dose oral contraceptives can be incredibly helpful. Now, not all women need to go on them, but again, for the right patient, that is often really, really good. So that's managing symptoms. But in terms of, and again, we can go lots into that's perimenopause management, about postmenopause or menopause transition management. But in terms of setting women up for a long and healthy life, one of the most important things, and this is something that I speak about and I'm really passionate about, and it's Breast Cancer Awareness Month in October, right? So this is what we're talking about today, but is helping a woman understand her individual risk of developing breast cancer. Because what we know, and the number that women know, is 12% lifetime risk. 1 in 8 women in their 40s are worried about getting breast cancer. Hopefully, they're getting their annual mammograms. But what is not well explained to women is that women have individual risks of developing breast cancer. And if I put 100 women in a room, every single one of them has a different risk based on family history, genetics, their breast density, their reproductive factors, how much alcohol they're drinking, what their diet is. And there are ways that we can help a woman understand her specific individual risk. So we can help her take steps to reduce her risk. And what we know is the terrible thing, I mean, we're doing a terrible job at this right now, is that we know that there are many women out there who are carrying genetic factors that put them at very high risk for developing breast cancer. We know that it's estimated that we've only identified about 10% of those women. We also know we put 100 women in a room, and I do this for community events where I have women, I put a group together. They give me the information in advance. I can calculate their individual risk assessment. Then I give a lecture about breast health and inform them of their risk. 25% of women sitting in a room are at high risk and don't know that they're at high risk, right? And so the reason that's so important is because if you know you're at high risk, you can do something about it. And what that doing something about it is twofold. The first fold is taking steps to reduce your risk, which lifestyle really, really is important. The other thing that women don't know in our very high risk patients is there's medication that women can take to reduce their risk. That's to prevent cancer. But then in the women at high risk, we want to be screening them more aggressively. So mammograms are not adequate in women who are at high risk. The same way when someone's at very high risk of heart disease, we don't manage them the same way we manage someone at low risk of heart disease in terms of continuing to monitor them. So women at high risk need a mammogram a year, but they also need a second form of imaging, right? So for me, and I'm a breast cancer survivor myself now, a little over 10 years, the most important thing is to find those women at high risk and make sure that we're talking about ways to reduce their risk, lifestyle, maybe medication, and then we're screening them much more aggressively. So if they get breast cancer, if we aren't successful at preventing it, we can detect it really early. And so that's one of the first things. And I can go on and on and on about every other things that I do, but I'll stop there for a minute.
So the breast cancer, and forgive my ignorance here, the ties between breast cancer and the perimenopause and the menopause, what's there? What are the ties there?
We are seeing early breast cancer, but in general, we start to see the incidence of breast cancer develop after age 40, which is why screening starts at age 40. Women can get breast cancer, throughout their life. We continue to have 80-year-olds who develop breast cancer, but it starts early. So what 40-year-old women are aware of is that now they're starting to get screened for breast cancer. And I would venture that every 40-year-old woman out there has a family member or a friend or someone they work with who's had breast cancer. Women in their 40s and 50s are worried about breast cancer. But the way that we are currently approaching breast cancer, which I don't think is adequate and we're working hard to make changes, is we just tell women to get their mammogram, right? But mammograms, number one, are not a perfect test, particularly in women who have extremely dense breasts, which women don't know about till they get their first mammogram. And even then, we aren't doing enough to educate them about what that means. Mammograms are a screening test to detect cancer that's already present, the same way a colonoscopy is what we do to detect colon cancer. But what we want to do is work to prevent breast cancer, right? Wouldn't that be a better goal? Like, we don't want to
Exactly.
get breast cancer, but we have to do more to identify women who are at high risk. If you don't identify the people that are at highest risk, you can't help them reduce their risk.
Wasn't there years ago, or I remember there's like a gene or there is an indicator in the genealogy, right?
Right.
Right.
So
Okay.
Angelina Jolie is the one
Yeah,
who has one of
it's
the BRCA
proactive.
mutations, and she has taken steps. I believe her mother died of ovarian cancer, so she was tested
Oof.
appropriately with a family history, and she's
Mhm.
taken steps to have bilateral mastectomies, take her ovaries out, because she's at very high lifetime risk of developing breast and ovarian cancer. And so truthfully, her steps, and we do this with women who carry those genes, and that's what I'm telling you, is that we think today only 10% of women who carry those genes that put them at very high risk have been identified. And there's been a big push now. In fact, I think it was just the Today Show was doing a big promotion one of the first days of October for Breast Cancer Awareness Month to raise awareness about the fact that genetic testing is available, that the price has come way down, and that we need to do more to get more women having genetic testing if they meet criteria.
Well, I mean, I just got to talk more about the science, and I hope the men that are listening out there, everyone is interested in this. Like, why is it breast tissue and ovaries and I mean, even testicles, which are very similar to ovaries? Like, why is that? Why are those tissues and those organs like so sensitive, to cancers, if you will? I'm just curious,
That's a hard question to answer because certainly we don't only see cancers in hormone-sensitive tissue. The breast is hormone-sensitive tissue, right? It responds to estrogen. We see big changes in breast during pregnancy when estrogen levels and hormone changes happen. I don't Breast cancer is complicated. Certainly hormones are not the whole story. We certainly know that environmental factors and lifestyle factors contribute. The patients that carry the gene mutations, there's something abnormal that genetically that is promoting the cancer, allows the cancer to develop. But yeah, it can't
Yeah,
really.
I'm just curious. I have a degree in biology, and I'm just fascinated with physiology. And it's just like it's like why there's these. I mean, obviously, there's many organs that are susceptible to cancer, but it's just like what we're talking about here. It's like, what about? So you mentioned earlier, I think it'd be very helpful for our audience about like communicating around this within a couple. So so what? I mean, 'cause, as you might know, or maybe you don't know, Dr. Lisa, I'm sure you do. It's like men like to fix problems and find solutions to things. You know what I mean? So we're always like kind of rushing in, with some sort of answer or whatever. So how do we communicate around this particular issue with it that might come up in the relationship because of these hormonal shifts that are affecting,
Yeah,
the
I mean,
relationship? Yeah. Hmm.
I'm not a sex therapist. I certainly refer to sex counselors frequently because
Yeah.
communication actually is the most important thing. And again, I'm not a therapist, so I can't. I don't really want to talk like I'm an expert here. But here's what I would tell you in my practice. What I see is that often women, I mean, they do come in often talking about declining libido. And the first and foremost thing I want to say is that it is hormonally related, but a lot of times there's other things that are going on that are contributing to the low libido, in addition to the fact that they're having hormonal changes. And it can be relationship issues that have been swept under the rug. It can be the fact that they're not sleeping because they have teenagers that are staying out too late and they're, whatever, or they're having, new hot flashes, or they're on other medications that are affecting their libido, right? So the first thing is in perimenopausal women who are having low libido and it's affecting their relationship and they don't like that, is they should seek medical care because we do have approved medications to help women with libido in the premenopause, perimenopause, right? So, um, really should start with medical care. But after that, I think it goes back to making sure that the conversation in the bedroom remains open and that couples are talking about what's going on, right? Because and I think men understanding that the change in libido and even in change in sexual response and orgasm function and all of that. I don't know how much you want to get into all of that here, but things start to change and it does require open conversation. And sometimes in when women are transitioning, sex becomes painful as well. And so things really you need to have conversations about this. What I will tell you I often see far too often is that women and men and their partners are not talking about it. And then what happens is they start to have sex very infrequently, then they stop having sex, then they're not talking about it. It becomes the elephant in the room. It really eats away at the relationship. And it becomes a real problem. And then what happens is, I mean, sometimes even though I said very clearly, I'm not a sex therapist, sometimes I have the partner come into the room as an internist with their partner, spouse, wife. And we just have a conversation about what's happening and have this kind of conversation about the fact that there's biology there and that depending on the specific issue that the woman's having, helping them understand that and treating that. Now, sometimes, again, it's more beyond just that simple visit. And as I said, I do a lot of referring to sex therapy, but communication matters.
So you talk about treating that. Is treating that necessary? I mean, it's a natural part of aging, right? Shouldn't what's the balance?
So again, I think that's a really good point. So the way that we define sexual dysfunction in women is whether or not what's happening to them is bothering them, right? Is causing distress. And what do I mean by that? Which is that the peak time of women having sexual dysfunction is in the 40s and 50s, right? That is a time when their often low desire is really affecting them and affecting their relationship, and they don't like it, and it is causing distress. Women in their late 60s, 70s, their desire often doesn't get any better. In fact, hormone levels, testosterone levels will continue to decline, but their partner is less interested in sex now, and it's not causing distress. So we certainly don't need to treat it then, right? So I want to be clear. If a woman's libido is lower in her 50s and it's not causing relationship distress and she feels okay about it, then of course we don't need to treat that. But again, I think that what I see is that's often a time when it is causing problems because their partner still has very strong libido and doesn't understand what's happening to them and why their libido is less.
So we talked about libido. What about, you talked about sleep, but I listened to Dr. Mary Haver
Yeah, right, sure,
on
yeah,
on uh, on Andrew Huberman, and
sure.
she talked about it's not just the libido, but it's confidence. It affects their
Sure.
work. Like
Oh,
I think she said, if I'm maybe be quoting this wrong, but 1 in 5 women stop working because of the lack of confidence.
right. Well, so and I don't think it's just lack of confidence and your data know that there's a huge impact on work. I mean, women will often make job changes, feel like they need to work part-time, that they can't do their job as well. They're having brain fog. There's lots of reasons that women will start to feel like they need to make job changes. And what we're a lot of us in the world of menopause that we work are working with employers. In fact, I have two lectures coming up to employers because employers now are recognizing the economic impact of women leaving the workforce at midlife and they have to look at ways to support them better through the transition. So just like talking to men as partners, we're really talking to companies now to create more menopause friendly workplaces because yes, definitely what women notice at midlife, and every midlife woman notices this, is that where she is noticing fat suddenly changes. She's got belly fat for the first time. She's got arm fat for the same time. She's gained a little bit of weight because women gain weight through the menopause transition. And certainly body image is part of sexual libido and being interested in sex and feeling confident in the bedroom for sure. And even that, like I think men understanding that what's happening is physiologic, right? That women's bodies are changing, that there's really biology there. And I think we're all doing this, right? Is you work very hard to exercise and eat right. And, if you're motivated on health, right? But what I tell women all the time is there has to be some level of your body's changing and you can work out the same, you can eat less. The scale might even not go up if you're really lucky and you're working hard at it, but your body shape still changes. You still have more belly fat than you used to. You still have arm fat, and you have to kind of accept what's a new norm and become comfortable in your own skin. But there's definitely a transition. I mean, so what I would tell you is, and I don't know your exact circumstances, but you know, the 40s as women are transitioning, again, this is very different than men. It's a really significant time of when they're no longer childbearing age, right? They know that their fertility is going away. It's often the time when teenage kids are starting to leave the nest. They're becoming empty nesters. They've been in relationships for a long period of time. Their libido's not so great. they're having a little more anxiety, they're not sleeping well, like just things don't feel right. And there's a lot of external things that are going on. So women during this time often feel like it's a time of loss, right? They're losing everything. They're losing control over their body. They're losing their kids. They're losing their ability to have children. They're aging. Men age much more gradually. There's not this big marker of suddenly when a man goes from feeling young to feeling old. I can tell you it's a marker. You become menopausal, you suddenly go from feeling young to old. And that transition is, it's coming as a woman, right? Like it's very, very different.
You mentioned menopause-friendly workplaces.
Yeah.
I
Yeah,
think that
I
was your
love that.
terminology.
Yes.
Yeah.
What would that look like?
Well, again, I
Yeah.
think it's knowledge of the fact that midlife women may be experiencing symptoms that they need to manage. So I think it's supporting good menopause care for women and trying to help them find access to resources, to education themselves so they can understand what's happening. But the most disabling symptom of menopause, which is the vast majority of women get it, about 80%, are these terrible hot flashes and night sweats. And it really impacts sleep. And I can tell you, as a woman who's been experiencing them now since I had chemotherapy for my own breast cancer, my husband, who lives with me, obviously, and I have these drenching sweats in the middle of the night. I mean, he says all the time, if men had to go through what you've been going through for 10 years with this, like we would have a cure by now. And the good news is we've been moving forward with science and we're getting much better at understanding what's causing these. But when they're severe, they're much beyond just being a little hot. And in fact, my father-in-law has prostate cancer, has been treated now, but medication that we put men on for treatment, anti-testosterone medication after their prostate cancer, gives men hot flashes. So my father-in-law was experiencing hot flashes at the same time I've been experiencing hot flashes, right? And he says it's absolutely, miserable, right? It's like a percentage of men will actually experience what this is. And that really often impacts work, right? So if you have companies that have, a lot of employees on a factory line, right, and they're having these drenching sweats, right, it's making workplace friendly environments where that can be addressed and managed without women feeling like they need to quit their job, and having a little more work flexibility for women that are having sleep disturbances related to this. And again, the recognition that this is physiology and real, and just like pregnancy, something that we need to support. Workplaces do great for having a policy about pregnant women and
Sure.
Hmm.
all of that, but
Breastfeeding.
yeah, right, a place where we support menopausal women.
Yeah.
Hmm.
Well, yeah, John, go ahead.
Yeah, I want to come. I want to come back to the treatment question. So I asked, like, why should it be treated? It's a natural thing. Why do we want to treat this natural thing? But what does the treatment actually look like? Because I know when men, like, so I'm retired military. Like, we were exposed to burn pits. I went out at night to do my operations, so my sleep cycles were just messed up, and my testosterone levels were very low. So the easy button is, well, testosterone replacement therapy for men. But women's hormones are so much more complex. What does treatment look like?
Right. So you've obviously been listening to some of Mary Claire Haver's podcasts, right? So you know a little bit about this, and as I said, I've been in the menopause space for 35 years. I'm past president of the Menopause Society, just going off the board now, right? Like I'm very involved in the space, and I can tell you, but those of us that have been working in the space this long have been shouting from the treetops that we need to do a better job to take care of women, and we really need to understand the science and the biology and the data about treatments and who needs to be treated. Um, it's only been in the last, 2 years, and really, I give Mary Claire Haver tremendous credit because the social media platforms and what she's been able to do, and many other physician kind of influencers who work in this space have been able to do, is really raise awareness, along with celebrities who have become menopausal or becoming menopausal and aging. And so it's really elevated the conversation. What we say when I lecture now, I say all the time, menopause is finally having a moment. Like, there's interest in this. The fact that you guys have called me to have you on your podcast, right? Somehow it's risen to the level of you guys noticing it, right? And where we are is the data about menopausal hormone therapy has been my entire career. And the brief summary is, for the first 10 years of my career, when I was really newly in this space as a new practicing internist, recognizing the need, the data that we had at the time came from observational studies. And from those studies, women who took hormones had less cardiovascular disease, lived longer, and we believed every woman should be on hormone therapy. So for the first 10 years of my practicing, all of my women were on hormones, right? I was treating them all because cardiovascular disease is the leading cause of death of women. And we were trying to prevent cardiovascular disease. In 2002, the big study came out called the Women's Health Initiative. And so everyone was on hormone therapy. And then that study, the way the data was presented, everybody stopped hormones. And not only
'Cause
that,
it
everybody
caused
stopped
cancer.
hormones, because
Mm.
and largely because of the messaging out there that 25% increase in breast cancer risk.
Oh,
The
jeez.
impact of that study is still being felt today, and the way the information was conveyed, and we didn't have social media to correct it, right? And to really try to present this in a way, we didn't have a microphone loud enough to get the data out there correctly. But women stopped taking hormones. They thanks to Suzanne Summers' move into kind of compounded bioidentical stuff, which is a whole different discussion. But doctors stopped prescribing hormones. Patients became fearful of it. You couldn't get a patient to go on hormone therapy, even if they were having terrible symptoms at that time. And really, over the 20 years since that study, because we really have come to understand the data, the pendulum moved back to the middle, where we really understand that this very big change in hormones, which men do not experience, right? So men don't have lots of hormones and go to zero testosterone ever, right? Never in their lifetime. It's very gradual. That change physiologically affects women. So we talked about all of the symptoms: sleep, hot flashes, low libido. But the cardiovascular risk increases dramatically. Women that are having bad hot flashes, there's something biologically different about them. They are at higher risk of developing cardiovascular disease. Bone loss rapidly accelerates through the menopause transition. Women gain weight, and that weight is associated with new development of diabetes and metabolic syndrome and things that are associated with cardiovascular risk. So many women, from a biologic basis, benefit from menopausal hormone therapy. And so I prescribe it all the time. And I'm a breast cancer survivor who is out there doing everything I can to prevent breast cancer. The breast cancer messaging about hormone therapy was messaged in a way that scared women inappropriately. And women have been deprived, and I say deprived because doctors became fearful of prescribing hormones. We stopped educating medical students and trainees about hormones. We never were able to get correct messaging to women. So this over-dramatized risk of breast cancer with hormone therapy is blown so out of proportion that women really have been deprived of hormone therapy when they would have gotten much more benefit. So I don't want to over-medicalize the menopause transition, because childbearing is a choice. If you live long enough as a woman, you're going to go through menopause. It is a natural part of reproductive aging. The difference, though, is, remember that in 1900, a small percentage of women lived 10 years beyond menopause. Now, life
Wow.
expectancy is into, 80, 79, 80. Women are
Yeah.
spending 30, 40 years beyond menopause, and the impact of those hormone changes is huge. And so, for specific reasons, there's really good reasons to treat women with menopausal hormone therapy. And so, again, uh, I could spend 5 hours, I often do, educating you about pros and cons of doing it. But um, for many women, menopausal hormone therapy is part of when I talk to women about a health plan to ensure healthy aging, menopausal hormone therapy is often, not always, part of that.
What about lifestyle? Like what you're consuming, what you're abusing, exercise, like how much does that play into this? And does that like create an easier transition or like kind of, kind of smooth out some of the mood swings or, what might be
So
happening,
again, there are certainly there's lots out there on social media right now about a lot of this. One of the good things about social media is we've gotten messaging out there about menopause. Women are starting to come in to see me now. They're not terrified of hormones. What it's also opened though is a big business and marketing. And what I say is any desperate menopausal woman, if you have good marketing and a pretty ad, you pretty much can sell them anything. And so there's a lot of people, we call it meno-profiteering in our world. There's a lot of people who are making a lot of money off of selling women not only a lot of expensive face cream, but a lot of other things. But back to your real point, nothing, nothing replaces a healthy diet. And the data about that is overwhelming in terms of healthy aging and maintaining an ideal body weight, not smoking, not drinking alcohol, and eating a Mediterranean type and moving towards a whole food plant-based diet is absolutely critical. And we know that 35% of breast cancers could be prevented if we got women doing everything they should be doing in terms of lifestyle. So lifestyle is critical. I can't overstate that. And maintaining ideal body weight is part of that. So all of these things that you're mentioning do help the physiologic changes that are happening through the menopause transition and are absolutely essential to healthy aging. I would tell you, though, the data on the majority of supplements is not there. And what I say for most women is it's probably not harmful. There's a huge placebo effect with taking supplements and menopause symptoms with all medications that if you take sugar pills, it can help your symptoms. But the data about really helping for the vast majority of them is not there. And most women are making expensive urine.
Yeah, right. Yeah, exactly.
Probably a lot of men are too.
Yeah.
So
And again, that's my opinion. I know you can get other
yeah,
people on here who will give you a
Right,
whole nother
right.
lens. And
yeah.
so you
We've had
yes,
other
that's
people
absolutely
giving
right.
the
So
opposite side.
again,
For the men who are listening, again, 70% of our listeners are men, and I don't know what percentage of them are married or in a relationship with women. But how do you approach this in a compassionate way, saying, "Hey, maybe we should go and look at getting healing or fixing this," and like it can look like the common man again, like Will referenced earlier. Hey, we're men and we want to fix things.
yeah, you want to fix things.
Um,
I would tell
yeah,
you it's encouraging her to get medical care if she's not getting medical care. If you're really seeing that she's having any of the symptoms, right? I think that's the first and most important thing. And again, if it's body changes that you're noticing, that she's noticing, midlife men have body changes too, right? Like,
Hmm.
the
what
spare
I
tire.
what I would tell you, right, is, and I talked to my own husband about this, right? Like, um, sex through midlife and beyond, you have to have a sense of humor. You have to have more patience. You have to be good communicators. You have to kind of laugh. I mean, it's just different than it used to be. And open communication about that is really, really helpful. And I think, again, if there is a disconnect in your relationship about libido, it's trying to understand that from the context of biology as opposed to judgment, right? And because that just adds to it, like judging a woman because she doesn't have great libido when it's really based in biology doesn't help the situation, right? And for midlife couples, and again, I'm not a sex therapist, but often, you know, planning for sex, talking about when you want to have sex openly, it's not just going to happen as routinely and frequently, and really planning sounds, corny. People say this all the time, date nights. I mean, really having conversations because, you know, partners who have low libido, I will tell you one interesting thing and think about it this way. So men have no trouble taking Viagra or Cialis. Men start to have trouble having sex they will pop a pill quickly. There are medications available to help women, a pill that they can take orally called Addyi every day that can help with libido. And there's an on-demand medication, an injectable medication that women can use that lasts about 14 hours that can help with libido. When that particular medication was coming to market, I believed incorrectly, I will tell you, that that was going to be a blockbuster and really take off because, again, the pushback I had been getting from women about taking the pill daily is that they don't want to take a pill daily. Again, these are typically younger 40-year-old women with libido problems, and they don't like taking medicine yet, and they just don't want to do that. But I thought an injectable medication that lasted, like 14 hours, that they would be really up for that. I can tell you that I prescribe it relatively frequently. Women don't refill it. They say when they come in, yeah, it worked great. It actually helped orgasm too. And yeah, I thought it was good. I just never think about using it. Right. So there is the difference. Right. Men have good libido, but their performance isn't great. They'll take Viagra because they have libido. Women don't have libido, so they don't even think about it. Like they don't think. And then it's an injection and it requires planning. And so the medication is approved to use up to 8 times per month. I typically have women, the 8 injections lasts them a year, right? So they don't do it very often. And so that's kind of, I think that highlights the difference between erectile dysfunction and having performance issues and having loss of libido.
Vulnerable moment here. I take Cialis, tadalafil, but not for that reason. I actually take it for two other reasons. One, because I have to get up in the middle of the night a bunch to pee, and I've been told this helps. And then 2, I've heard through Joe Rogan and Peter Attia that tadalafil is one of the pills or medicines rather, that can really help with longevity. And hopefully everybody understands longevity. I mean, longer life, not
not larger penis, John. Oh, come on, John. You're ruining the conversation. I'm just kidding.
So, are there, and I guess like you talked about before, as far as the cardiovascular disease, the estrogen, progesterone, that can help with that. So in a sense, that is their longevity. That is the female longevity equivalent of tadalafil.
I certainly know about other podcasts, and I certainly see what's going on on social media. So the conference I was just at, I was one of the organizers of the conference. This was a physician conference. There were 280 physicians there. And I pushed on the experts at where we are with the data today about menopausal hormone therapy as a longevity drug regimen. And I would tell you, and this is an area, frankly, we don't agree on as clinicians based on the data. And that is not my opinion. I certainly prescribe a lot of hormone therapy. I am not prescribing it as a longevity regimen. I am prescribing it for very specific reasons in individual patients. And the majority of women have hot flashes, and the majority of women are really good candidates for hormone therapy. But the decision to prescribe hormone therapy is indicated right now for symptoms. But I would tell you it does have cardiovascular benefit, but I think the breast health issues are really important and are under-addressed, right? Because I would argue that a woman at very high risk of developing breast cancer compared to a different woman who's at low risk will have a different impact with hormone therapy depending on what formulation is given and what dose. And so the messaging which is out there now that now all women should be on hormone therapy, I personally I believe that that's not the correct messaging and that we should not be messaging hormone therapy as a longevity approach.
Okay.
I know that that's out there. So you take my opinion for my opinion.
Wow.
Interesting. No, that's good to know, because the first thing I want to do is, and not specifically about the libido piece, is like, hey, I want my wife to live longer. I want her to have
Yes.
a healthier life longer.
Yes.
And I want to run to her and be like, hey, take hormone replacement therapy.
Well,
But
so well,
maybe
so
that's not the,
right, and hormone therapy may be really appropriate for her, and she may be a good candidate, but the way that I approach a midlife woman is I do several things. I want to assess her breast cancer risk. I wanna understand what that is. I wanna give her what her 5-year, 10-year lifetime risk is of developing breast cancer. I wanna talk to her about her cardiovascular risk. We call it her ASCVD risk score. I wanna tell her what her 10-year and lifetime risk of developing heart disease is.
so what was that? The ASCBD?
ASCVD, CVD, cardiovascular disease. You can go on and do your own calculation if you know your cholesterol results.
Wow.
Okay.
Okay.
And then I wanna assess her bone health. I wanna know, is her bone quality good, low already? Like, I really wanna understand this. I really wanna understand her family history to know if there's anything there that we need to be specifically worried about. And then I wanna look at her symptoms. And I wanna take all of those domains in her health, and then we come up with what's a appropriate regimen to ensure a good health span. And lifestyle is always part of that discussion. But every woman sitting in front of me, this is why my menopause consults are really 90 minutes, because it really takes time to do a good evaluation. What I often, unfortunately, am seeing now is just everyone's kind of being started on hormone therapy. And the problem with that is, and it's, I don't believe we should be calling it a longevity drug, and it misses the opportunity to evaluate all of these domains in a woman's health. So, like, she's still, you may be prescribing hormone therapy, she doesn't know what her breast cancer risk is. So, you have no real ability to talk to her about how hormone therapy might be impacting that risk of developing breast cancer. You have no ability to talk to her about lifestyle to reduce breast cancer risk or what her cardiovascular risk is, right? So I think I'm afraid that we've gone from everyone on hormones to no one on hormones to where we understand the data. And now we're going back to everyone on hormones with, and I think that harms women too, because we're missing opportunities to individualize and personalize care specific for that woman.
Good to know. Okay, perfect. I think that right there is a very important message
Yeah,
for
exactly.
the men listening too, because if they listen to half the show, they might be like, "Oh, I'm just going to tell my wife to get on
Well, so
HRTs."
let me make one point about that, which is, in my community where I practice in Cincinnati, but certainly from the conference I was just at, which was physicians from all across the country. We are all seeing a lot of patients that are getting these hormone pellets put in their rear end every 3 months, right? And women are getting that because of low libido and because they've been told that, again, now menopausal hormone therapy is a longevity regimen and everyone should be doing it. The problem with those pellets of testosterone, and my consultative practice in Cincinnati, I spend a tremendous percentage of my time taking women off pellets, because they come to me after 2 to 3 years now having the side effects of the high dosing of the testosterone that they're getting. So the pellet dosing is too high for women. And I've seen crazy levels in my practice. So the way we think about it is men's testosterone level typically is between 300 and 900, women is under 50. And I've seen women come into my office after a pellet with levels of 1200, right?
Oh
As
my
you
gosh!
remember that we use
Wow.
testosterone in our transgender patients. So in trans
Hmm.
men, we're using testosterone. We are dosing their testosterone levels in the 400 to 600 range, and they're having masculinization that they want from the testosterone. So women, when they're getting these high dose pellets, come in with the first pellet. They feel so great, they run around telling a million of their friends to get a pellet. And by the 8th pellet, they're now having all the side effects and they're spending a lot of money on it and they want to get off. And that's when they come to me.
Yeah, and the dangers of that, I mean, in men, like I get tested for this regularly, is my testosterone can cause my hematocrit levels to be high, which could cause that could cause stroke, throwing a clot. I mean, that's, and I'm assuming the dangers of that are in women as well. I mean, at 1200, like that's bodybuilder level.
Yes, one of the things, I mean, and I've seen this several times too, is when men are taking testosterone from a lot of these testosterone clinics, um, they often don't tell their primary care doctor that they're getting testosterone. And I've had this twice happen in practice where a patient has had their annual blood work done, and all of a sudden their blood work is really, really abnormal, right? Their hematocrit is really, really high, and they're not getting appropriately managed, and their levels are too high too. In women, we know, and I don't know the data as well in men, but in women, there's a sweet spot for testosterone. And as women push the dose, their libido doesn't always get better. And in fact, over time, even with these high doses, women, we call it tachyphylax. The brain gets used to those higher doses of testosterone, and then they don't have the same benefit. And that's why women end up coming to see me. They're starting to have hair loss, their acne, voice change. They've now started to gain weight. They're spending money, and the testosterone pellets the high dose doesn't seem to be helping them as much anymore. And they also have genital changes that are often very bothersome to women, and don't want that. So again, the high dosing in women, I am 100% opposed to. And so I speak out very frequently about. No to pellets.
Yeah.
No to pellets. There we go.
Wow. Well, anything that we're going to close in a sec here. Anything that you feel or that our male listeners should from this conversation, like what would be the big takeaway, to them if you got a message for them?
That women are not crazy during this time. That what men, their partners, if their partners are noticing is based in biology, and that it's real. Try to encourage your partner, your wife, your girlfriend, whatever, to make sure she's getting really good medical care. Acknowledge that if she looks different, is gaining a little bit of weight, and her libido is a little lower, she's not sleeping as well. Again, it's not that she's crazy. These are hormonal changes. This is part of how women age. Women age differently than men, and it's kind of really working hard to keep that relationship together, particularly, again, at midlife when things are changing very quickly for women.
And communication is so incredibly important during that time, really understanding your partner, what they're going through. Wow. Excellent.
Absolutely excellent. I'm going to go back and listen to this 2 or 3, 4 or 5 times just for my own benefit. So Lisa, thank you so much for this. This has been tremendous, and I know our listeners are going to get a lot out of this, both the men and the women. So, Will, you want to wrap it up?
Yeah, no, I just want to say thank you. I mean, this is really great information. It's obviously the landscape is continually changing around this, and hopefully there's more like a cohesive, body of knowledge and a way forward in the next 5 or 10 years. And I know you're working so hard to make that happen. So thank you for putting the work in. That's all I got. Thank you. Yeah.
Well, thank you, Dr. Larkin. We very much appreciate you, and it was a pleasure. Great conversation. And for our listeners, thank you for tuning in. And I know you got something out of this episode, so share it. Share it with your female friend. Share it with your male friend. Share it with everyone who you believe could get something out of this. And we appreciate your listening. And until next time, take care, everyone. Bye-bye.
Thank you for joining us today. We hope you walk away with some new tools and insights to guide you on your life journey. New episodes are being published every week, so please join us again for some meaningful discussion. For more information, please check out mentalkingmindfulness.com.